Good evening, everyone present here. I am Faraz from IGCP Group. Welcome all the participants on today's live session. And let's welcome our speaker with great honor, none other than Dr. Pragad Beniwale sir. And let me share some of the achievement of sir. Sir has done MD, FICOG, FICMH, Director of Beniwale Women's Clinic, Senior Consultant OBGY, Pune, and PG Teacher and Unit Head at Kamala Nehru Hospital, Pune. And today, sir is going to discuss on a topic, very important topic, that is management of endometrial hyperplasia. To know more this about this topic, I would like to invite sir and hand over this session to sir. Over to you, sir. Kindly proceed further.
So, thank you. And, good evening, all. I bring greetings from Pune, and it's indeed a pleasure to be talking to you all about endometrial hyperplasia. Thank you, team IJCP, for inviting me here to talk about this very important problem, which is seen to be on the rise. When we talk about human reproduction, we know the functions of the ovary, and we know that the ovary produces estrogen and progesterone. So whenever there is increased amount of progesterone as compared to rather increased amount of estrogen as compared to progesterone, it is likely that the endometrium is proliferated much more, and which eventually may result in endometrial hyperplasia. So we know that the uterus is a complex but tissue. It contains many cell types. There are steroid hormone responsive cells and which undergo changes during the phases of menstruation. So this is a picture which is familiar to all. Typically, the proliferative phase is under the influence of estrogen, and the secretory phase is where progesterone is added to estrogen, which brings in menstruation on time. So anovulation is a problem where the progesterone is not generated in good quantities. So there is endometrial response to abnormal levels of steroid hormones, and the hyperestrogenism, poor stroma would lead to degradation of microvascular system. So endometrial hyperplasia is characterized by proliferation of endometrial glands of irregular size and shape. And when we compare it with the proliferative endometrium, there is an increase in the endometrial gland to stroma ratio. So endometrial hyperplasia virtually always results from chronic estrogen stimulation unopposed by the counterbalancing effect of progesterone. In short, it is the anovulatory cycle which would be responsible for endometrial hyperplasia. So endometrial hyperplasia has a spectrum from benign to malignant, and it is important for us to understand its presentation, what are the risk factors, how to diagnose it, and very importantly, management strategies. So typically, women will come to us. They may be in any age group, but perimenopausal age group is one where this is by far most common. So they will come to us with abnormal uterine bleeding, and typically they would have heavy menstrual bleeding. There could be intermenstrual bleeding, irregular vaginal bleeding, and there could be unscheduled bleeding while the women are taking hormone therapy, or sometimes they may present to us as post-menopausal bleeding. Coming to the risk factors, and it is important that we understand these risk factors, because whenever any woman comes to us with any of these risk factors, we should be vigilant. This is a woman who is likely to be having or harboring endometrial hyperplasia. So obese women, where there is increased BMI, there is excessive peripheral conversion of androgens in adipose tissue to estrogen, may result in endometrial hyperplasia. Anovulation, which is associated with polycystic ovaries or even with perimenopause, may result into endometrial hyperplasia. Rarely estrogen secreting ovarian tumors like the granulosa cell tumor, drug-induced endometrial stimulation, where the use of estrogen replacement therapy, or women who are receiving tamoxifen as a part of breast cancer therapy. And of course, there could be some element of family history which may be responsible in this. So, how do we proceed when we are suspecting a woman with endometrial hyperplasia? It is important to remember the checklist. Don't forget to take detailed history because history may clinch us the necessary diagnosis. Clinical examination is very, very important. There are certain laboratory tests which we would like to do, which would include a CBC, a blood sugar level, creatine, thyroid levels, and even liver function test. Transvaginal ultrasound is something which is very, very important because it will give us the exact clue about the thickness of endometrium, and the color Doppler will also tell us about the vascularity which is present in that endometrial cells. Endometrial sample histology will clinch us the diagnosis. Of course, hysteroscopy and hysteroscopic guided biopsy has its own role to play, and MRI is needed in very, very specific situations. So, after a good clinical examination, we do subject women to a transvaginal ultrasound. And let me tell you that it is a very, very important diagnostic tool, and it will tell us all the details that we are looking at. So, it may tell us more about the uterus, it may tell us more about the endometrium. In fact, experts in this field would be able to tell us what kind of endometrial pathology to suspect just by giving us a good picture of a transvaginal ultrasound. So there could be we could be dealing with a woman who has a polyp, or there could be submucous myoma. It could be a vascular polyp, and the Doppler will show us the feeding vessels. The endometrium may appear secretory or early proliferative or even late proliferative, and all these findings will guide us as to how to investigate this woman further. So, looking at the endometrium better by a transvaginal scan, of course, in young women who are not sexually active, we have to rely on the transabdominal route, where we must have a look at the endometrial pattern before taking the further step to confirm the diagnosis of endometrial hyperplasia. And the polyp, which are so commonly seen these days, are best diagnosed by a good transvaginal scan. Salpingography or sonohysterography is something which would clinch the diagnosis, wherein it will be very, very clearly seen hanging around in the endometrial cavity. So, how do we diagnose endometrial hyperplasia? I mentioned earlier about the history. History can be a pointer. If we are dealing with a woman who's diabetic, who's obese, we think of endometrial hyperplasia. Evaluation on transvaginal ultrasound is important. If you are dealing with a woman who is postmenopausal, we must remember that the cutoff for postmenopausal woman is 5 millimeters or even 4 millimeters in some cases. But if the endometrial thickness is more than 8, in postmenopausal woman, we must think or we must suspect endometrial hyperplasia. Hysteroscopy is very, very important. Hysteroscopy will tell us what kind of pathology we are dealing with. So we may be able to see a polyp, we may be able to see the thickened endometrium, or we may be able to appreciate the vasculature when we put in a hysteroscope. So any postmenopausal woman who comes with bleeding and we are suspecting endometrial hyperplasia, it is worthwhile putting in a hysteroscope. However, in a young woman who's maybe in her 30s or 40s, hysteroscopy may not be performed routinely. But for postmenopausal women, it is important. And if you have a high suspicion for endometrial carcinoma, then it is prudent that we put in a hysteroscope, have a look at the endometrial cavity. So this is how the endometrial hyperplasia will look, and we should not forget the increased vascularity, which will tell us how the endometrial pattern would look like. And of course, it is important for us to rule out the polyp. Is noted in about 9%, and many a times it is because of the proliferation or excessive proliferation of endometrium, and we should keep in mind possibility of malignancy, because on ultrasound it may look like just a thickened endometrium. Sending it to a good histopathologist is important because the histopathological diagnosis will tell us the further course of action. So when we classify endometrial hyperplasia, there was a time when we used to call it DIN, we used to call it cystic glandular hyperplasia, etc., etc. But in 2014, WHO has started a new classification, and it is something which all of us are using, and that is endometrial hyperplasia without atypia or atypical endometrial hyperplasia. Now, management of these two will certainly be different, and we should be clear in our minds as to what kind of treatment we are going to offer. And of course, if you are suspecting a malignancy, if you are suspecting atypia, or if it is a doubtful scenario, it may be worthwhile taking opinion of a senior histopathologist, because we don't want to undertreat or overtreat the woman who is suffering from endometrial hyperplasia. So this is the revised classification, and we have to keep in mind that if we have a diagnosis of hyperplasia without atypia, there is less than 1% chance that this will progress to invasive endometrial cancer. However, if we are dealing with atypical endometrial hyperplasia, there is a 25 to 33% coexistence of invasive endometrial cancer. So we really have to be very, very clear in our minds when we are making a histopathological diagnosis. So endometrial hyperplasia definitely is a challenge for treatment, and uh, the treatment modalities have changed. The Green Top guidelines released in 2016 talk about transvaginal ultrasound to clinch the diagnosis of endometrial hyperplasia, hysteroscopy wherever indicated, and LNG intrauterine system as the treatment of choice when we think of endometrial hyperplasia. But it is important that we counsel these women very, very well. Whenever we get a diagnosis of endometrial hyperplasia, there could be some concerns in the mind of women because they start thinking in terms of malignancy. So we have to give them complete information of the problem and with documentation. Possible treatment modalities will be explained. There could be medical options, there could be long-term or non-surgical options, there could be surgical options which need to be discussed with benefits as well as possible side effects. Whenever we are offering medical treatment or conservative treatment, we have to tell them about the efficacy and possible recurrence. And if the therapy fails, they have to understand that they have to undergo possibly a surgery and a radical procedure to take care. Can we do only observation? Well, spontaneous regression of endometrial hyperplasia without atypia is possible. There are chances of relapse to be considered, but these women have to come up for follow-up very, very regularly and frequently. So they may visit your clinic every 3 months or every 6 months. If there are certain risk factors present, we must change management strategy and think of medical therapy. Coming to medical therapy, and of course, the drug of choice will be progesterone. It can be given orally, it can be given vaginally, or even it can be given in an intrauterine system, fat turn. But it is worthwhile giving a continuous therapy in order to make sure that the endometrium is suppressed. It may be inconvenient, but there could be a good regression. And of course, the woman has to make a choice after a good counseling. So progesterone are the mainstay of treatment for any kind of anovulatory bleeding, and it is 50% of the total prescribed drug for endometrial hyperplasia. So progesterone have antimitotic effect on the endometrium. They stimulate the 17-beta hydroxysteroid dehydrogenase and sulfotransferase activity. These enzymes will convert estradiol to estrone sulfate. They inhibit estrogen's induction of its own receptors and suppress estrogen-mediated transcription of oncogenes. and they would eventually induce endometrial atrophy and prevent proliferation of endometrium. So, a continuous administration of progesterone is desirable in a woman who has endometrial hyperplasia. So, we can consider giving her norethistérone or even medroxyprogesterone. It is typically given in the dose from the 5th day to the 25th day, and this would result into significant reduction in the blood flow to the uterus. Emergency dose can be 15 to 20 milligrams per day for norethistérone and about 30 milligrams per day for medroxyprogesterone acetate. But we have to make them aware that there could be mood changes, there could be fatigue, weight gain, headache, loss of libido, uh, because these are the things which are typically seen with endometrial high doses of progesterone. So the treatment of choice probably is the levonorgestrel intrauterine system. LNG intrauterine system is something which has a long-acting reversible therapy which releases progesterone, that is levonorgestrel, in the dose of 20 micrograms per day. It suppresses the endometrial growth, and after a few weeks of insertion, the endometrial glands become atrophic, the stroma becomes swollen, the mucosa becomes thin, and the epithelium becomes inactive. Uh, Thus, the heavy menstrual bleeding, which is associated with endometrial hyperplasia, is taken care of. There is certain anti-inflammatory reaction characterized by increase in neutrophils, lymphocytes, plasma cells, and macrophages. There are vascular changes which include thickening of arterial walls, suppression of spiral arterioles, and capillary thrombosis. So all these would have an impact on the endometrium as well. The endometrium becomes unresponsive to estrogen, so it doesn't proliferate anymore. There's no change in factor 8. Number of bleeding days and the volume decreases by about 60% in levonorgestrel users. Mind well, this doesn't happen overnight. One has to wait for a span of 4 to 6 months before we see this good effect, and 35% of them do report improvement in dysmenorrhea, which could be noted right after the first or second cycle. So typically, the LNG intrauterine system would bring in changes in the bleeding pattern, and typically these women may experience spotting for first 3 months. In the next 3 months, the spotting becomes less, and after 6 months, about 40 to 50% women do become amneric, which is probably the desired side effect, and typically the symptomatic relief would be there once the drug starts acting well. There are certain side effects which we have to keep in mind. Some women do experience irregular bleeding, typically so in the first 3 months. So counseling is very, very important. Some women do experience mastalgia, cyst formation, skin problems, dislocation, or expulsion are rather uncommon, but it has to be kept in mind. Chi et al. Way back in 1993 have stated that amenorrhea could be there in about 20% of women by the end of the year, and this is because of the thinning of the endometrium and uh, the increased resistance to the blood flow going to the uterus. So it does give relief from dysmenorrhea. It protects the women from PID, and it also acts as an excellent contraceptive with an efficacy of 99.9%. Clinical trials have shown that there is almost 80% continuation rate after about 12 months. The side effects are typically noted commonly in the first 3 to 6 months, and counseling is very, very important in order to continue the use of LNG intrauterine system. The ACOG in 2010 has very categorically stated that a systematic review found that levonorgestrel system to be an effective treatment for hyperplasia without atypia, with a regression in about 96%, which is definitely good. However, accurate diagnosis and ongoing surveillance are essential. And why one chooses LNG intrauterine system? Mind well, it is an office procedure, it is reversible, it of course saves a lot of money and saves a surgery like hysterectomy. It has a good client satisfaction, there is definite improvement in quality of life, and since it avoids operative treatment, there is wide acceptance in women. So the Green Top guidelines in 2016 talk about management of endometrial hyperplasia, and what they and these are their recommendations for AUBM, that is endometrial hyperplasia with atypia, EA to be repeat endometrial aspiration to be repeated 6 monthly for close monitoring. Endometrial ablation is not recommended in such women because it doesn't ensure complete destruction, and then the histological follow-up becomes difficult. We must keep in mind these special categories: women desirous of pregnancy who have atypia. So for them, it is prudent that they use LNG intrauterine system for about 6 months, or receive high doses of progesterone continuously for a span of 6 months. There is regression possible uh, in the endometrium, and then they would they can go ahead with the fertility treatment. But it is important to have two biopsies performed uh, to rule out atypia. It is important that continued endometrial surveillance is mandatory. So we have to think of a repeat ultrasound after about 6 months, and if there is still persistence of thickness in the endometrium, a repeat endometrial biopsy on an OPD basis is warranted. If there is endometrial hyperplasia without atypia, well, the treatment of choice is essentially progesterone. But if the woman desires so, one can think of a hysterectomy, which could be done vaginally, abdominally, or laparoscopically. Mind well, we need to retain ovaries in order to have the benefit of hormone productions, and it is worthwhile taking away the tubes, which are now found to be the culprit for ovarian cancers. Women who have endometrial hyperplasia with atypia, or those who progress to atypia or who have a relapse, then hysterectomy with or without adnexectomy is what is needed. There is no need to do lymphadenectomy, and only when it is malignancy we have to think of doing uh, lymph node dissection. So, what are the current guidelines say about management of endometrial hyperplasia? Investigate with a transvaginal ultrasound and color Doppler. Histology in select patients classify into two groups: without atypia and with atypia. Management would depend on age, parity, and risk factors. We can think of an LNG intrauterine system or oral progestogen. Try it continuously for 6 months. If we have atypia, if the woman has completed family, hysterectomy would rather be prudent. But for high risk patients, it is important that we do a follow up. And if you are continuing with progesterone in the high doses, uh, the, it should be done every 3 to 6 months. And counseling, of course, is an integral part of the treatment. So this is the algorithm for AUBM, where we try and rule out endometrial malignancy. Of course, the protocol will be totally different. And then depending on the endometrial histology, we decide what kind of treatment to offer. So if there is atypia, then obviously hysterectomy is the definitive treatment. But if there is uh, hyperplasia without atypia, conservative treatment like LNG intrauterine system is very, very important. Right. So thank you very much. And once again, thank you to Team IJCP for having me here.
Thank you so much, sir, for taking out your valuable time and sharing your knowledge on this topic. I definitely think this session knowledge is going to help all the participants on their practice also. Sir, I have received some questions, sir. With all your permission, shall we take these questions?
Sure, sure, sure.
The first question is from Dr. Agarwal, and he's asking, how do you differentiate between simple and complex endometrial hyperplasia, and what are the implications for management?
Okay, first of all, the term simple and complex are out. It is now the hyperplasia is either it is without atypia or atypia. So earlier there was simple and complex. So these terminologies are not there. So it either has to be hyperplasia with atypia or without atypia. If it is a simple message to remember is that if it is with atypia, there is high risk of developing into malignancy. So radical treatments like hysterectomy are important. But if it is without atypia, it has to be essentially uh, the conservative treatment, which includes progesterone therapy.
Thank you so much, sir, for answering this question, sir. Moving forward, I can see one other question, sir. Like from
Mhm.
Dr. Subramaniam, he is asking what are the benefits and limitation of using Lenogestral intrauterine device (LNG IUD) compared to
IUS.
oral progesterone in management of endometrial hyperplasia.
Okay. Now, whenever we are giving oral progestogens for managing endometrial hyperplasia, we have to note that they have to be given in very high dose for a longer duration of time. I did mention that it has to be given at least for 6 months continuously. Now, whenever we are whenever we are prescribing or whenever we are asking a woman to take oral progestrogens, there are a lot of side effects which can take place, and some important ones include changes in the lipid profile. And progesterone, for that matter, is not very friendly with the lipids. So my personal choice is LNG intrauterine system because here the target organ is endometrium. We are putting the device inside the endometrial cavity. There is a fixed dose of hormone progesterone, that is levonorgestrel, that is released inside the uterus, and studies have shown that minuscule quantities are absorbed in the body. So there are generally no systemic side effects seen with LNG intrauterine system. It is a simple OPD procedure. Practically, it takes 2 to 3 minutes, but good counseling is important. And if it doesn't suit a woman, you can always remove it and then think of some other treatment. But we have in fact used a lot of LNG intrauterine systems for various indications, including endometrial hyperplasia, maybe in about 700 odd patients in last 20 years, and the results that we found out are really great. The only thing that has to be remembered is that the patients need continuous surveillance and monitoring. They have to be seen by you every 6 months. A good transvaginal scan every 6 months is important, and if needed we can think of a repeat endometrial biopsy. Now, endometrial biopsy also is done on an OPD basis with the use of a small device called PIPEL, which again is a 2-minute procedure where anesthesia is not required. So the follow-up has to be on an OPD basis, and if needed, repeat histopathology is important.
Thank you so much, sir, for answering all the questions, sir. As I can see, sir, there is no more question. I hope that you have done justice to this topic and all the audience are happy with the solution, sir. As there is no more question, with all your permission, shall we conclude this session for today?
Sure, sure, sure. Thank you very
And it
much,
was
and I
welcome.
hope to see you all again in another session soon.
Yeah, thank you so much, sir. It was really nice to have you. And till then, take care of yourself. We would like to see you in future with different topic. Thank you so much, sir.
Sure. Yeah. Thank you.
Bye,
Bye
sir.
bye.